All right, we're going to get started on our final lecture of the day. The lecture to follow this one is actually not a lecture. It's going to be a very fun, what? Sort of a lecture, I'm told. An audience response session with some questions to sort of prep you for Monday's exam. But before that, we have our final lecture of the session. I'm very pleased to introduce Dr. Kristen Burkhart, who is an associate professor of medicine on our faculty. She is one of our critical care faculty. She is the program director for our fellowship program in pulmonary and critical care medicine, and she's an expert on the epigenetics of COPD. She's going to be talking to us today about COPD, chronic obstructive pulmonary disease, and smoking cessation. So it's my pleasure.
All right, so good morning, everyone. Let me know if you have problems hearing me. I generally speak loud enough. This is going to be hopefully a session where you feel free to ask questions, interrupt, and as the talk goes along, I just sort of wanted to start. All right, I'm already having technical difficulties, but while we're figuring that out, we'll start here.
Should be able to click that. Didn't work? Okay, try again.
Oh, sound. Where's the sound? So these are our patients with COPD. These are going to be the patients that you care for. And I'm going to spend the rest of the session talking about COPD emphysema and smoking cessation. That ad, some of you may or may not have seen, that's actually a New York State Department of Health ad for smoking cessation. And there have been a series of these have come out. I have no financial or other conflicts of interest to report. By the end of this session, you'll be able to describe risk factors, signs and symptoms of chronic obstructive pulmonary disease, diagnose COPD and apply a guideline approach to the management of COPD, and describe different management strategies for smoking cessation. If I could, it would be nice. It's the slide forwarding.
Oh, I thought you wanted the red pointer.
No, I want both. Okay. I like to walk.
The red
I'm a walker, so I'm trying to get my pointer settled out here. I apologize. So I don't like to stand behind the podium. Okay, so during the course of this lecture, we're going to go over COPD prevalence, burden, and mortality. So basically, why do you need to know about COPD? How do we define COPD? And what are the different COPD subtypes and phenotypes? What are the most common risk factors associated with COPD? The signs and symptoms of COPD and how you diagnose it. Then I'm going to focus on management principles of stable COPD. So I'm going to avoid COPD exacerbations, talk about how we assess and treat using guidelines, and then end with some smoking cessation. So why are you learning about COPD? Why is it important to all of us as healthcare providers? COPD is a major cause of mortality and morbidity throughout the world. Just over 15 million U.S. adults are diagnosed with COPD, and it's a widely under-recognized and underdiagnosed disease. There are some estimates that put COPD up to 24 million U.S. adults at this time. It is the second leading cause of death, or the second leading cause of disability in the U.S., the third leading cause of death in the United States, and the fourth leading cause of death globally. COPD costs over $50 billion a year to care for patients with COPD. This is a common disease, and it is lethal. Between 1970 and 2002, the death rate from heart disease halved, while the death rate from COPD doubled. And when you look at the literature out there, the majority of our common diseases, we've had improvement in our survival statistics, except for COPD, and a slight uptick in diabetes over the last 20 years. So what is COPD? How do we define it? And what are the various COPD subtypes? So the purest definition of COPD is airflow limitation that is not fully reversible on post-bronchodilator therapy. Specifically, an FEV1 to FVC ratio that is less than 0.7 on post-bronchodilator spirometry. So this is the key part of that. It has to be post-bronchodilator spirometry, which makes it non-reversible, right? So you've all learned about your spirometry. You do a pre and a post. If you get reversibility and you go above 0.7, that does not meet criteria for COPD. This is what your airflow obstruction.
The point it does.
Okay.
Right.
Okay. Yeah. All right. So this is what your airflow obstruction looks like. All right. So this is a normal flow volume loop. This scooping right here is consistent with moderate airflow obstruction, and this would be severe airflow obstruction. And this is the pattern that we expect to see on patients with COPD. So again, COPD, I'm going to say this multiple times because it gets complicated and confusing. The key, post-bronchodilator spirometry with a ratio less than 0.7. But it's not just that. There's subtypes, there's phenotypes, something called emphysema, chronic bronchitis. And most recently added into this definition of COPD is a chronic obstructive asthmatic. So not someone that reverses on airflow obstruction on their spirometry, but someone that progresses to fixed obstructive airways disease. For the purpose of this talk, I'm really going to focus on chronic bronchitis emphysema as the elements of COPD. Remember, this is only a subset of patients. So when we talk about COPD, I'm only talking about the red. I'm missing emphysema that does not have airflow obstruction. I'm missing chronic bronchitis that does not have airflow obstruction. And I'm not differentiating between people with airflow obstruction that have emphysema, chronic bronchitis, or neither, and just have airflow obstruction. So it's a complicated disease, and although we've lumped them all together, they act very differently. So to give you a little bit more information about emphysema, so pathologically, emphysema is permanent enlargement of air spaces distal to the terminal bronchioles with destruction of alveolar walls. You're going to, looks like Swiss cheese, right? So this is a pathologic specimen of the lung. This is what a normal lung should look like. Now, we're not looking at pathologic specimens in general of lungs when we're taking care of patients, but we are looking at chest CTs. And what we see on CAT scans is loss of lung parenchyma. I don't know if you can see it very well in the back part of the room, and you can't. But in your slides, perhaps, or in a dark room someplace when you're looking at them, what you see, thank you, the same Swiss cheese appearance that you're seeing on the pathologic specimen you see on your CAT scan. As you become involved in medicine and clinically more active, you'll notice that many patients get CAT scans for unclear reasons or for reasons that may be unrelated to diagnosing COPD or emphysema because it's not part of our diagnostic criteria. And you'll note that a lot of people do have emphysematous findings on their CT scans, and it may be the first sign or symptom that you actually see for patients to continue the workup. What this results in clinically is destruction of gas exchange surfaces. There are different emphysema subtypes. So there's central lobular emphysema, which is primarily seen in smokers and upper lobe predominant. There's panlobular emphysema, which we associate with alpha-1 antitrypsin deficiency and is lower lobe predominant. Then there's paraseptal emphysema that is localized to the septae and the pleura, and can be seen in isolation or with central lobular or panlobular emphysema. Chronic bronchitis is fairly straightforward. It's not rigorously studied, but it's clinically quite useful. So the definition of chronic bronchitis is chronic productive cough for 3 months in each of 2 consecutive years without being able to identify different causes of cough. So not bronchiectasis, not postnasal drip, not GERD, productive cough for 3 months in each of 2 years. This may precede airflow limitation, it may follow airflow limitation, or they may not develop airflow limitation. So understanding the pathophysiology of COPD will help understand some of the physiologic presentations of COPD and some of the classic findings that we look for. It's important to realize that although the pathologic changes occur primarily in the airways, it is also seen in the lung parenchyma as well as pulmonary vasculature. Chronic inflammation and airway fibrosis results in narrowing of the small airways, and then destruction of the lung parenchyma by inflammation results in loss of alveolar attachments to small airways, which decrease the elastic recoil that typically keeps the airways open during expiration. So again, think back to your talks that probably Dr. Bowman, Dr. Atkinson gave you, looking at your spirometry, looking at your airflow limitation, right? Generally, we can get most of that air out of our lungs in that first second of forced exhalation. Patients with COPD cannot do that. As hard as they try, they cannot do that. Their airways collapse as they're exhaling, and as they collapse, it takes them longer to get their breath out. That's based in the pathology and the physiology. If you look at a volume time curve, this isn't in your slides, promise, you'll get a new upgraded slide. It's just more to sort of display this exhalation. This is your patient's predicted curve of exhalation. This is your forced expiratory volume in 1 second. This is how long it takes him to get there, or her. And look how long they exhale for, up to 11 seconds to get to FVC, whereas FVC is hit right here where they should be. Their airways are constantly collapsing while they're trying to exhale, and this factors into their symptoms and their presentations. I'm going to talk a little bit about risk factors. I think most people in the room probably are aware that exposure to tobacco smoke is by far the most significant risk factor for COPD. Includes cigarettes, pipes, marijuana, hookah, whatever you want to smoke. Anything that is smoke and going in your lungs results in COPD. Environmental tobacco smoke exposure has been associated with the development of COPD and airflow obstruction. Anywhere between 15 and 50% of smokers will develop COPD, and this huge range goes back to the fact that we really feel like it's an underdiagnosed disease. So depending on what source you're looking at, you're getting 15 to 20% versus 50% of smokers. People are also living older. They're living longer. And so smokers are now developing COPD later in life than perhaps was seen in earlier studies. However, 20 to 25% of COPD patients are never smokers. So tobacco smoke is not the only risk factor. There's environmental and occupational exposures. Chemicals, dust, fumes. So work environments tend to be a risk factor for COPD. You have to talk to your patients when they come in, when you're asking them about risk factors. It's not just tobacco smoke. Where do you work? What are your exposures? Indoor air pollution. I believe you already heard from Dr. Schluger about global health. So this is probably the largest cause worldwide of COPD, burning of biomass fuel. We have projects ongoing in Ghana right now looking at development of airflow limitation with biomass fuel production, or biomass cook stoves. So genetic risk factors. By far and away the most well-accepted and established genetic risk factor is alpha-1 antitrypsin deficiency. So as Dr. Bowman stated, I do genetics of COPD, and it's a complex trait, and it requires multiple genes by environment interactions. There's been maybe 4 or 5 genes that have consistently popped up as risk factors for COPD. It's certainly not prime time, certainly not ready for clinical medicine, and ideally the goal will be to find pharmacotherapies that can affect those specific genetic risk factors that go along with it. Minus alpha-1 antitrypsin deficiency, and this is prime time. So alpha-1 antitrypsin is inherited via an autosomal codominant transmission. It's encoded by the gene SERPINA1, and the alleles are M for normal and Z for an abnormal allele. So alpha-1 antitrypsin is a protease inhibitor, and so the genotypes are set up to denote that it's a protease inhibitor, so PI, and then what allele you have. How many alleles are normal, how many alleles are abnormal. And so that's the PIMM, PIZZ, there on the genotypes. Right now, it's estimated 1% of people with COPD or emphysema, I should say, have alpha-1 antitrypsin, but again, it's probably underdiagnosed and underrecognized. We're probably not testing enough people to look for the disease. When should you be thinking alpha-1 antitrypsin deficiency? What does emphysema from alpha-1 antitrypsin deficiency look like? People are young. They are 30 to 40 years old with tobacco exposure. Most people will not develop emphysema from tobacco, pure tobacco exposure, until they're in their 40s or their 50s. You have a patient who comes in with emphysema, and they're 32 years old, and they have severe lower lobe emphysema. Again, distribution. Remember back to that emphysema slide we talked about. Panlobular, panacinar, lower lobe distribution in a 32-year-old person, in a 40-year-old person, even in a 50-year-old person. You need to be thinking about alpha-1 antitrypsin deficiency. Should send off a level, and the indications to treat are a level less than 11 micromoles per liter. That's when the belief is that levels below that result in emphysema. Again, we'll talk about this a lot about treatment, but alpha-1 antitrypsin deficiency, you must not be smoking, A, to receive augmented therapy, and B, to prevent the progression of this disease. So this is taken from the internet. Right? So courtesy of Jeremy Jones, I got a couple. He has some nice radiology up there for us to look at. Really impressive lower lobe emphysema right there. Okay? And this is a classic looking panlobular emphysema scan of somebody who may be at risk or have alpha-1 antitrypsin deficiency. So we've talked about tobacco exposure, environmental exposures, genetics. Just briefly going to mention socioeconomic status. And I actually think this is critical when we talk about healthcare disparities and where we're at with who's at risk for COPD, who gets COPD. And the poorest people in our country have the greatest risk of COPD. When you look at people who make in the $25,000 or under range, about 9% of them have COPD, 9% of the entire population. When you look at people in the higher classes, greater than $100,000 a year, 2% of people. Okay? So lower socioeconomic status. It affects the poor. It affects people who probably are not educated and are smoking. When you look at smoking rates, it correlates with that in terms of socioeconomic status. It actually was always traditionally thought to be a man's disease, right? This classic man smoking emphysema that we saw up front. More women are being diagnosed with COPD now than men because women picked up smoking later in the history of tobacco use. So it's a very commonly seen in women. Women tend to do more poorly than men with COPD in terms of morbidity, mortality, and progression of disease. So what are the signs and symptoms, and how do we diagnose COPD? The hallmark, there are three hallmark signs of, correction, three hallmark symptoms of COPD. Dyspnea is one of them, all right? Killing me without my pointer so I can walk around. Sorry, I have to keep hovering back to the podium. So this dyspnea is progressive. It's characteristically worse with exercise. It is persistent. It does not go away. And critically and importantly, patients actually may not recognize it. So emphysema and COPD is a disease that slowly progresses over time. And what patients do is 5 years ago they could walk 10 miles. 3 years ago they could walk 4 miles. Now they walk a mile. Now they walk a block. Now they can go from the sofa to the kitchen. And when you ask them if they're short of breath on exercise, most of them will say, no. When you probe them and ask them for further information, and they say, well, I can only walk from here to here, and you ask them why, they'll say, I don't know, it's just what I do. Right? So you have to ask them, you have to get at it. They don't understand. They're getting older. Just getting older. I'm heavier. I'm overweight. All of these things factor into it. So you need to make sure you're asking the detailed questions to your patient. They have chronic coughs, and they have a chronic production of sputum. So these are the sort of classic symptoms of COPD. I'm going to go through a case. This is a 67-year-old man who presents to your office complaining of dyspnea while he's climbing stairs. He doesn't have any chest pain. He's a 50-pack year smoker, but he quit 3 years ago when he was diagnosed with pneumonia. At rest, his heart rate's 78. He's breathing on a respiratory rate of 18, which if you look at the nursing notes, that's normal. It's a little bit tachypnic, right? Normal respiratory rate's 12 to 14, but generally every patient you're seeing in the hospital at least will have a respiratory rate of 18. And they're satting 90, that's true, and they're satting 95% on room air. You have him climb a flight of stairs in your office because he's complaining about dyspnea. So you take him and you walk out there and you put a pulse ox on him and you go to the stairwell and you climb with him. And you notice that his heart rate goes to 105, his respiratory rate goes to 32, and his oxygen drops to 91%. You bring him back into your office, you sit him down, his respiratory rate comes down, his oxygenation comes up, and you do a physical exam. He has decreased breath sounds throughout bilaterally. He doesn't have a wheeze, but he has a prolonged expiratory phase, and the AP diameter is increased. He has something called a barrel chest. This is the chest x-ray you get. What do you think? Normal? You can just yell normal, abnormal. Okay, good. What's abnormal? Correct question. I'm sorry? Lung volume. Okay, so a marker of lung volume, right, is this really obviously flattened diaphragm. Good. So you get this chest x-ray. He's a smoker. He has dyspnea. You're thinking to yourself, he may have COPD. So you order pulmonary function tests. You have an FEC of 2.81, an FEV1 of 0.64, which is 26% predicted, and a ratio of 0.23. And this is his flow volume loop. So what kind of defect does he have? Obstructive ventilatory defect. Great. And that would be consistent with COPD if I told you this was a post-bronchodilator spirometry. So why might he be short of breath? I'm going to argue he has dynamic hyperinflation. And I'm not going to spend a lot of time going through the physiology, but I'm going to do short because I know Dr. Bowman has already done this. But I'm going to go through a short exercise. And it's actually sort of hard to do, but I want everybody in this room to take as full, deep a breath as you possibly can. Exhale halfway. Take another full, deep breath. Exhale a quarter. Take another full, no, don't exhale all the way out, all the way. Hyper-expand yourself. Get yourself as full as you can. And now take short, shallow breaths up there. That's what your COPD patient is feeling. That's what they feel when they're walking. It's awful, right? It's uncomfortable. You can't get a breath. You can exhale all the way out and get that out. They can't. So as soon as your respiratory rate increases, you cannot get all that breath out. I'm gonna ask you guys to try that at home a little bit, sort of get a real feel for what it's like, because it's very, very uncomfortable. So it's a key component of managing people with COPD. What are the clinical consequences of dynamic hyperinflation? Your limitation is from exercise. You become dyspneic. You hypoventilate, right? So all of that air in your lungs, and now you're breathing in these tiny little volumes. You almost have dead space ventilation. You're not getting out to the alveolar space. So you have alveolar hypoventilation. You have worsening hypercapnia. You have cardiac dysfunction. They get so hyperinflated. You guys have done your cardiology stuff already? You get so hyperinflated that your preload returns. You have this huge intrathoracic pressure, and they drop their preloads. You have cardiac dysfunction with dynamic hyperinflation. Dynamic hyperinflation is an independent risk factor for survival in COPD. And pulmonary rehab and exercise training is a key element of how we manage patients with COPD, and they're limited when they have dynamic hyperinflation. So you sit your patient back down, like I said, in the room, and you see this person breathing like this. Inspiration, expiration. Does anybody know what this is called? Pursed-lipped breathing. Good. So it's instinctive for many, but it can be taught, right? So if you have a patient with severe emphysema who's not instinctively picked this up, it's a really easy thing to teach them. Do a count of 2 to inhale through your nose, count of 4 to exhale out. Results in decreased dyspnea, decreases dynamic hyperinflation by decreasing your respiratory rate, prolonging your expiratory phase, and it reduces the dynamic airway compression by generating extrathoracic PEEP. So it increases the expiratory airway pressure, which inhibits that collapse that we see pathologically. What do you expect to find on exam? Expiratory wheeze, prolonged phase, decreased breath sounds bilaterally, and increased AP diameter or barrel chested. Distant heart sound. Don't be listening to your patient wondering if they have a heart, right? It's so quiet I can't hear it. It makes it harder to hear the murmurs. Someone with severe disease, somebody in an exacerbation, they'll be using accessory muscles, they'll have paradoxical breathing of their abdomen. They will be pursed-lip breathing. They'll be sitting in the tripod sitting position, and they're not able to speak in full sentences. So when you look at a good physical exam and a physical exam note documenting severity of somebody with lung disease, these are what you should be looking for. We're going to say someone's speaking in phrases, I'm worried about them. Somebody's speaking in words, oh, I'm really worried about them, right? And so it helps us gauge how sick somebody is, how well they're compensating for their disease. Do you guys use Netter here? Yes? Okay. So everybody's seen this picture, right? It's just a drawing from Netter about what he thinks it looks like, or not. Okay? So this is a patient with COPD who is pursed-lip breathing and sitting in that tripod position. It helps them from a mechanic standpoint. It helps them from a PEEP standpoint to breathe. I've actually seen more than one patient in my life come in with olecranon bursitis and a bursa infection from their tripod sitting. Right. Does COPD cause clubbing? No. Okay? This is a common misconception, and I put it in here simply because of the number of times I've had a patient with COPD and someone tells me their clubbing is from their COPD. My heart sinks just a little bit because COPD is not associated with clubbing. So if you have a COPD patient with clubbing, you need to look for lung cancer, right? Another cause of the clubbing. So yes, COPD is seen in interstitial lung disease, and our clubbing is seen in interstitial lung disease. It is seen in cystic fibrosis. It's seen in shunts, so congenital heart disease, prolonged hypoxemia. Hypoxemia, it's a neuroendocrine-mediated process. It's rarely associated with COPD. And in truth, I think we're missing whatever the cause is if someone says it's from COPD. So always be thinking of another diagnosis. These are what you're going to be looking for in your patients with COPD. You're going to be ordering pulmonary function tests because you need them to diagnose it, right? You're going to be looking at chest radiology, chest x-rays, chest CTs. Whether you order them or not, the vast majority of patients in the healthcare system have had one or both of these at some point in their exposure to us. Arterial blood gases are going to help you from a severity of underlying disease. And then the 6-minute walk test. So you have a patient who comes into you, no diagnosis, new patient to the system, has never been seen before, and they say, "Doc, I feel," they're giving you the history. You don't even have to ask them. "I feel short of breath, coughing up sputum all the time. I have smoked for many years. Oh, by the way, I work in some chemical fume factory," right? And they've been exposed to biomass fuel on their trip to South America, right, for prolonged periods of time. So this is the patient as a slam dunk. Get spirometry on them, right? You need to look for them. This is not in the classic indications for spirometry, but you have a patient who had a chest CT because they had chest pain and somebody thought they had a PE when they had a rib fracture and they got a chest CT, and you see emphysema on your CT scan. It is reasonable to proceed to spirometry to look for the diagnosis of COPD and see if they actually have airflow obstruction associated with it. So we've talked quite a bit about the role of spirometry and how we need it to diagnose COPD. So you cannot diagnose, quote, COPD without a post-bronchodilator spirometry. It helps you determine the severity of airflow obstruction. It helps you determine the severity of COPD. It'll help you determine your management strategy for your patient with COPD. You can also use spirometry to follow disease progression. So you don't need to check spirometry every month, every 2 months, probably at most every year. If somebody is stable, you'll get spirometry just to see the progression of their disease. You also get lung volume measurements, and you can see an increase in your residual volume in your TLC, indicating air trapping and hyperventilation or hyperinflation, and you'll see a decreased DLCO. So again, this is a more impressive chest X-ray that I showed you before, and our eyes are always drawn to that diaphragm, right? It looks really flat to me. It's got a tiny little heart hanging there. There's something else quite notable on that chest X-ray. Does anybody see it? Yeah, right? So again, just to give you some visuals, this is what we expect the diaphragms to look like laterally. That is what we expect a normal retrosternal airspace to look like. His is gigantic, right? This man is going to have an increased AP diameter on exam. He is going to have decreased breath sounds throughout. You're not going to be able to hear his heart when you're listening to him. Here's some more chest CT findings, again, just sort of trying to demonstrate this sort of almost Swiss cheese looks of your lung. The lucencies is the emphysematous destruction. I'm not going to spend a ton of time on this. We all talk about using blood gases to help us look at the severity of our COPD patients. Pulse oximeter won't help us with hypercapnia. So the main cause of hypercapnia and hypoxemia in COPD is actually ventilation perfusion mismatches. So beyond that, for hypercapnia, there's those mechanical insufficiencies. On top of that, you put somebody in that dynamic hyperinflation standpoint, tiny little tidal volumes, rapid little respiratory rates. They're actually going to increase their dead space to tidal volume ventilation. Effects of supplemental oxygen on hypercapnia and COPD. Has anybody heard about this? Anybody have any concerns about this? Is this something that we're overly worried about? Anybody? Okay, so I need audience response next time. So yes and no. So I'll tell you, traditionally speaking, people are incredibly worried about giving oxygen to COPD patients because we see them become more hypercapnic, develop hypercapnic respiratory failure, and they need to be intubated. And we know that that worsens the mortality very, very rapidly in somebody who's COPD and gets intubated. So we get nervous about doing it. The mechanisms behind it are mixed and not as straightforward as initially described many, many years ago. So many people still quote this, and you will hear this, and I'm here to tell you that it's not 100% accurate, okay? That giving oxygen blunts the hypoxemic drive, and that's why they all get hypercapnic. It's a small percentage of it. When you look, maybe their PCO2 is up by 4 to 5 in a lot of recent studies looking at it. The sort of philosophy behind that is that, you know, they get so used to being hypercapnic, their pH no longer drives it, their hypoxia is what drives their breathing. You give it to them and they slow down their respiratory rate, they slow down their drive. That has been shown and studied. When you do that, they do drop their minute ventilation a little bit, but that may ultimately actually help, right? So you think about that increased respiratory rate, what that does. It decreases your alveolar ventilation. So by slowing down your respiratory rate, it's mixing and helping. One of the other hypotheses, and there's many, I'm not going to go through them, but I find this one the most interesting and probably the most relevant, is that it messes up your hypoxemic pulmonary vasoconstriction. So you give somebody oxygen, and now you're vasodilating those capillary beds to an area that's not ventilating well, but you can get enough oxygen in there to vasodilate them. And so again, worsening VQ mismatch. So the key take-home points I want you to take from this is that yes, it can worsen hypercapnia, but you need to give it to them if they're hypoxic, right? So hypoxia is bad, causes all sorts of problems from a cardiovascular standpoint, from an end organ perfusion standpoint. But you need to monitor it closely. You need to keep your goal sort of 88 to 92% on your pulse oximeter. So how do I tell a patient with COPD how well they're doing, right? Do I have anything that helps me predict their prognosis, how long they're going to live? What can I tell them? So it turns out in 2004, Barcelli et al. Sort of did something called the Bode Index, and it's probably the best and should be the most widely used predictor for COPD survival. I would argue that not everybody uses it because some of the elements may appear too cumbersome, but they're actually quite easy to do. So what this stands for is Body Mass Index Obstruction Dyspnea Exercise. So BMI, you all should know. Obstruction is percent FEV1. Dyspnea is using the modified MRC, and then exercise is a 6-minute walk test. And it's quite remarkable. If you take somebody who's in the higher scores, okay, and I don't need you to memorize this, I just want you to understand this is out there. This is a resource available for you guys to use on your patients. If you have a 7 to 10 on your Bode Index, you have an 80% mortality at 3 years, compared to somebody with a 0 to 2 who has a 20% mortality. So it is quite helpful and a useful tool that I personally think is underutilized. So let's talk a little bit about management principles for stable COPD. The Venn diagram is back. But really, the important part on this at this point, I've talked about this already, that this is how we define COPD. It's also how we define it for every single interventional trial we have ever performed in COPD. And we've never looked at people saying, well, they have this obstruction, but they really have a lot of emphysema compared to the person without emphysema. Or we haven't looked at just emphysema. And there's been really a big push in COPD management, studying sort of science, ultimately changing clinically, hopefully what we do, to sort of say, we need to differentiate these phenotypes to study COPD and make a difference, right? So emphysema is not the same as airflow obstruction. Airflow obstruction on its own with emphysema is probably different than just airflow without it. And so we are limited in our data in terms of how strong our results are for managing people, partly because we have limited ourselves on trial recruitment. So we have very sort of few management sort of criteria. Vaccinate your patients, please vaccinate your patients. Influenza, pneumococcus, Prevnar, okay? Smoking cessation. Pharmacotherapy, which is what all those randomized controlled trials were about. Pulmonary rehabilitation, I'm really going to spend no time on this. This could be an entire talk of its own, truthfully. But to realize that pulmonary rehabilitation is incredibly valuable for your patient's quality of life, to improve their ability to function, and is part of a management strategy. Oxygen therapy, when indicated. And then different surgical options. Again, I'm focusing on stable COPD. So pharmacotherapy, medications that we use for COPD are primarily used to prevent and control symptoms. They decrease the frequency and severity of exacerbations, and they can improve exercise tolerance. But No randomized controlled trial to date has shown to modify the long-term decline in lung function using medications. Okay, and so this is key. And most of us are really hopeful that it's because we haven't defined it properly. We need to separate it out and look for different ways to treat people differently. Because remember back to the very early part of my talk, heart disease has halved, mortality has halved in the last 30 years, and COPD has doubled. We need to do something better. What do we have available as clinicians, as people caring for our patients? We have bronchodilator therapy. We have inhaled corticosteroids. Systemic corticosteroids are not recommended in management of stable COPD. Again, you're going to reserve those for your exacerbations. And then there's other medications that have recently come out, azithromycin and roflumilast. I'm really going to talk about the staples, so bronchodilator therapy. So these are inhaled beta-2 agonists. You'll hear the term LABAs and short-acting beta agonists. So a short-acting beta agonist, albuterol, Ventolin, whatever you want to sort of shorthand to use it, but this is sort of the mainstay as-needed inhaler, okay? Long-acting beta agonists, LABAs, so salmeterol is the one that people are most aware of. Then we use inhaled anticholinergics. So ipratropium is a short-acting inhaled anticholinergic. Tiotropium, or TO, for those of us who use the language, right? You're going to hear people are going to throw random stuff at you when you get on the wards, right? And that's a long-acting muscarinic antagonist. It's called a LAMA, right? So this is going to be language you're going to hear and you're going to stumble across it. And then theophylline is falling out of favor. It is a bronchodilator that is taken orally. Has a really narrow therapeutic window, and just a little bit over is quite toxic, so most people don't use it anymore. It's hard to get some of your old-time COPDers off their theophylline, although it's becoming fewer and fewer people. Inhaled bronchodilators are the preferred, and LABAs or LAMAs are preferred over short-acting medications, okay? So this is different. What you're hearing now is going to be very different than how you manage asthma, okay? So in COPD patients, there is no role for using an inhaled corticosteroid on its own. I'm telling you I would use a long-acting beta agonist on its own, which is completely opposite of how we manage asthma. All right, so just to keep that clear, it's medical malpractice for me to give somebody with asthma salmeterol on its own. There's an increased mortality with that. You cannot put them on a long-acting beta agonist without inhaled corticosteroid. Okay, it's not quite a strong statement in COPD, but the management guidelines say do not use ICS alone. Use it in combination at minimum with either a LABA or a LAMA. Okay? So using inhaled corticosteroids with LABAs or LAMAs can improve lung function, decrease exacerbations. They are synergists, so they work better than used in isolation. The triple therapy is probably better. Comes with a consequence. Every trial done looking at inhaled corticosteroids has shown an increased risk of pneumonia. So you have to use it judiciously. This is where the no role for ICS alone comes, right? So our COPD patients who get pneumonia, who get on the ventilator, I've now just shortened their life, right? So you have to use things when indicated and appropriate. Long-term oxygen therapy improves survival in COPD. I've given you something. One thing that I can do to improve survival in my patient that is oxygen, which is why we go back to that slide a few slides ago talking about please use oxygen in your patients who need oxygen, okay? I know we get fearful of it. I know we're afraid to use it because they may get hypercapnic and end up on the ventilator, but I can improve your survival. So severe COPD with hypoxemia, this is in 1980, looking at people with an FEV1 of less than 30% predicted and a PO2 of less than or equal to 55 millimeters per mercury or an arterial oxygen saturation of less than 88% had improved survival on oxygen therapy. Okay? So this is the mainstay of our oxygen prescription for our patients. Is the first one that's highlighted in green that we talked about. There's been a broadening of it that you can be a little more loose with a PO2 of 56 to 59 or a blood oxygen saturation of 89% if they've demonstrated sequelae of hypoxemia, cor pulmonale, pulmonary hypertension, findings consistent with congestive heart failure, or hematocrit greater than 56%. So of all of, of all of these interventions that we talked about, just about every one of them improves survival, or symptoms, right? So vaccinations probably don't improve your symptoms. Smoking cessation will ultimately improve your symptoms. The pharmacotherapy improves your symptoms. Pulmonary rehabilitation improves your symptoms. Oxygen therapy improves your symptoms, and surgical options will improve your symptoms. What do I have for survival? Very little. I have smoking cessation. I would argue vaccinations, all right? So you give my COPD patient their vaccinations and they don't get influenza and they don't get a pneumonia, then I've improved their survival. There's not a lot of great data for it, but most people embrace that concept. Oxygen therapy, when indicated, and surgical options in a very select group may improve survival in COPD, but the sort of classical teaching for things that improve survival in patients with COPD are smoking cessation and oxygen therapy. All right, so we're getting to this called the GOLD. GOLD, people heard GOLD? Probably not. You will. It's the Global Initiative for Chronic Obstructive Lung Disease, and it's a global strategy that was started probably about a decade ago now for the diagnosis, management, and prevention of COPD. And it's a combined assessment of COPD. So in your patients, they tell you how to very objectively assess symptoms, to assess the degree of airflow limitation using spirometry, and assess the risk of exacerbations. And taking all of these together, we aim to improve management of COPD, and that's the whole purpose of the GOLD Initiative. So how do we assess symptoms? So I talked about this a little bit on the BODE index in a very objective manner with modified medical research dyspnea scale, or the MRC questionnaire, or you can use the COPD assessment test, or the CAT. This is what it looks like. Everybody talks about the New York Heart Association classifications for heart failure. Very few people use the MMRC. And if you've ever heard Bart Celli talk, who is the person who did the BODE, he goes crazy about that, right? It's very simple. It's easy to ask your patients to answer this question. You can hand it out to them and have them fill it out while you're doing different things on them. How short of breath are you? Do you get short of breath with strenuous exercise? Well, that's a grade 0. I am too breathless to leave the house, or I'm breathless from dressing and undressing. That's a grade 4. It's a really simple question. It takes 3 minutes at most for a patient to 30 seconds, depending on the language, but it's very quick. The other one is the assess symptoms with CAT. And I'm showing this for 2 reasons. There's an app, so the COPD Foundation, so Dr. Thomashaw is actually within our faculty, and he's very involved in the COPD Foundation. They have an app that they've created, and part of that app contains this assessment tool and references for different guideline managements. And this is what it looks like on the app. So you can actually go through this with your patient very quickly with an app in your phone and objectively assess their symptoms. Assess degree of airflow limitation, we've already talked about spirometry. And assess the risk of exacerbation. You have to look at this, you have to take time to process this. This is not to have you understand this completely right now, but really to know that it's out there, so that when you're clinically taking care of patients, you know that you have the GOLD management strategy to use to help you decide what to use for your patients. On the bottom is your symptom score, right? So the cutoff here, so first look at your symptoms. Are they mild? Are they more severe? And then you look at risk, and you take the category that is the most severe, and you pick a box, basically, and you assign them a GOLD criteria. And by doing that, you then can assign them what medical management is the appropriate management for that disease state. Okay? This is assessing symptoms, exacerbations, spirometry, helping you figure out the best way to manage. This is sort of expert opinion. I can't tell you that this has been a rigorously studied randomized controlled trial, but this is what the vast majority of the world has embraced for managing COPD. They have non-pharmacologic management for patients with COPD. And I think the key things here, again, smoking cessation is essential for everybody. Physical activity is recommended for everybody, and vaccinations are indicated for everybody. Pulmonary rehabilitation, we talked briefly about this, but it is a key component of us managing our patients with COPD and keeping them active in their lives. This is another guideline approach. Again, this is the COPD Foundation. This is on that app. Just to realize there's ways to help you manage your patients. So surgical options. So lung volume reduction surgery. So the NET trial is this big, multi-center, randomized controlled trial looking at surgical interventions for emphysema. Overall did not show a difference. We did a subgroup analysis, and we looked at people with severe upper lobe predominant disease with decreased exercise capacity. This group of patients with COPD actually have decreased long-term mortality. And Dr. Bowman's very active in our LVRS program, and our results here are quite good. So we have an incredible improvement in patients, both from a morbidity standpoint and in improved mortality compared to baseline, other groups to compare to. Lung transplantation, interesting, is a little bit more controversial still. So COPD is becoming the most common indication for lung transplantation. But whether or not it actually improves survival is still not clear. And so up front, there's increased mortality. If you can make it through the early parts of the surgery, your mortality may ultimately go down, but this is still fairly controversial. Depends on single lung versus double lung. So there's a lot of complex decisions that get made into managing your COPD patients when it comes to lung transplantation. So I'm going to end on smoking cessation. So about 21% of adults smoke. 70% of smokers want to quit. Half of smokers want to quit within the next 6 months. 80% who attempt to quit on their own relapse within a month. And only 3 to 7% of smokers who quit on their own are abstinent 1 year. So why do people smoke? Everybody knows this, but it's the nicotine. Truthfully, the most dangerous and lethal consumer product on the market, right? All of the medical comorbidity complications from tobacco and mortality. This quote is an interesting one. So the cigarette is among the most awe-inspiring examples of the ingenuity of man. Think of a puff of smoke as a vehicle for nicotine. Smoke is beyond question the most optimized vehicle of nicotine. Any idea who might have made that statement? The senior scientist for Philip Morris back in 1972. Okay. So take a few nice breaths. Pleasure, reward, comfort. This is why our patients smoke, okay? It is an addictive drug. This is what they feel, and it's an incredibly hard thing for them to quit. So why are we talking about it mixed in with COPD? The next few slides, just take a moment, look at them. They're not in yours, but you'll get them, all right? So nearly 50% of U.S. adults aged 40 to 79 with lung obstruction are current smokers. And if you look, the more severe your lung disease, the greater percentage of people are current smokers, right? So people with COPD are still smoking. They cannot quit, despite the fact that they're short of breath. They can't walk, all from their cigarette smokes. If you look at FEV1 in the lung health study, again, this is an intervention trial looking at smoking cessation. The blue line here are sustained quitters, the red are intermittent quitters, and the green are continuous smokers. This is the loss of lung function over years. If we can get people to quit smoking, we slow the decline of lung function. Smoking cessation decreases all-cause mortality at 14 years, almost 15 years. If you look at the respiratory disease, just looking at that, it's remarkable. These are your smoking cessation people. It's a huge difference in people with COPD. We have to get them to quit smoking. So, again, I just want to, this is a paper that came out in 2013, just looking at when you get people to quit smoking. So if you get them to quit between the ages of 25 and 34, they gain 10 years of life. If you get them to quit between 35 and 44, they gain 9 years of life. If they quit between 45 and 54, they gain 6 years of life. And if they quit over the age of 55, they gain 4 years of life or less. So we need to get them to stop smoking before they develop COPD. We need to get them to stop smoking as early and as young as they walk into our clinics. And that's really our responsibility as physicians. Nicotine addiction should be treated as a chronic condition similar to asthma and diabetes. Cigarette smoke is the leading cause of preventable mortality. And the process of becoming a next smoker is facilitated by counseling and treatment. Okay? Remember, 1 to 3% of patients or people who try to quit smoking are successful at 1 year if they've tried to do it on their own. We are an integrate part of this. Your job is the 5 A's. Ask, advise, assess, assist, arrange. Okay, these are the basics of smoking cessation. Ask every patient you encounter about tobacco use. If they smoke, advise quitting at each visit. There's incredibly strong evidence to suggest that even 3 minutes of your time talking to a patient about quitting smoking makes a difference. The quit rates go up, the abstinent rates go up. Assess their readiness to quit. You'll often say, well, I'm not quite ready, but maybe next time. Don't give up on them. Don't let them give up on themselves. If they're ready to quit, assist them. And then arrange for follow-up with them 1 week after the quit date. So how do you, as a physician, assist them? You set a quit date with them. You address any potential barriers to quitting. Talk to them what to expect about nicotine withdrawal syndrome. What are their environmental triggers? Talk to them. Like, do you like to smoke after your morning coffee, at the end of a meal, when you're drinking alcohol? Try and help them prepare for ways to intervene upon that. People have concern about weight gain and depression. These are real concerns. Address them up front. And then discuss various treatment options with them. So for smoking cessation, the first-line pharmacologic treatments are combination nicotine replacement therapy. So that means patch, plus the gum, plus a spray, plus a nasal spray. Excuse me, Wellbutrin or Zyban, and then Varenicline or Chantix. All of these are better than placebo. Most of the meta-analysis of combining lots of studies sort of say that nicotine replacement therapy that's in combination format or Chantix are probably slightly better than the Wellbutrin for quitting smoking, but they're all considered first-line treatments. Active smoking is not a contraindication for nicotine replacement. Okay, I think that's the other thing people worry about. You have to provide counseling and support groups, and unfortunately, even here at this institution, there's not a lot of funding or availability for that, and so we don't have a smoking cessation clinic here. The New York State has a hotline for you to call, as you saw. Many of the sites, so I believe the COPD Foundation has a 1-800 number for you to call. So a lot of the counseling and support is over phone calls and visiting with people. And there's alternate therapies that have been put out there, so acupuncture, hypnosis. These have not been proven, but some patients have success with them. The role of electronic cigarettes or vaping is still quite controversial. And again, I suspect that Dr. Schluger has touched on this, since this tends to be one of his passions, so I'm not going to spend a lot of time with that. But I am going to talk about public policy and how it can help with smoking cessation. And I think this is probably one of the most impressive things that you can see. So we are down almost 35% since 2002 from a smoking standpoint in New York City. We increased New York City and New York State taxes. Maybe we drop a little bit. We're pretty consistently here at sort of 21.5%. We get down to 19% with that increase in tax. Now we make it a smoke-free workplace. We get down to 18.3%. We give out free patches. We're helping people quit with medicines. Maybe we get a slight uptick, but it's probably just variability. And then we start doing the hard-hitting media campaigns, right? I don't know how many of those New York State DOH commercials you've seen. The one I showed you up front is incredibly uncomfortable to watch, even for me who takes care of patients with it. There are some that are even more graphic and more uncomfortable. Imagine being the mother of a child watching that one where she's having to tell her young children she's dying of lung cancer, right? So they are hard-hitting and they've made a difference. It's controversial. People feel they're maybe too graphic. I would say that we went from 17.5% to 16.9% smoking, and I think it's important to let people understand the consequences of the choices they're making. And then over the last few years, with increases state taxes, increases in federal taxes, and another increase, we're down to around 14% in 2010. That's really remarkable, and I think it's impressive. We're lower than most of the country, actually. So the keys to tobacco cessation is that it slows the loss of lung function, it improves survival, it requires counseling and treatment, and will not happen if you do not ask your patients about tobacco use and you do not advise them to quit. So just in summary, COPD is common, it's underdiagnosed and deadly. We define it as a FEV1 to FVC ratio of less than 0.7 on post-bronchodilator spirometry. Tobacco cessation and long-term oxygen therapy are the only interventions proven to prolong survival of patients with COPD, and we should all be using a guideline approach to manage patients with COPD. Thanks.
We have time for a couple questions if anybody has a question for Dr. Burkhardt.
How often do COPD patients present with bronchitis and emphysema, and is there any causal relationship there?
So the sort of causal relationship is probably all tobacco smoke, and just different, I would argue, as someone who studies genetics, different genetic sort of underpinnings that sort of lead you towards one pathway or another. There's not, that I can tell you, there's not a lot of great data. There was a healthy person study looking at how many people have chronic bronchitis and emphysema and how much they overlap, but there's no large sort of COPD cohort that people have looked at to see which percentage of them. That's actually currently being worked on. And so there's a lot of ongoing studies right now really working on the phenotype and differentiating out emphysema versus COPD and chronic bronchitis. And so we actually hope to have that information more reliably in the future. Sure. So it's co-dominant, and so it actually, it's, again, not super straightforward, but homozygous normal will not have it, okay? But you can be heterozygous and have a slightly lower, so if you want to use the term gene dosage, I guess we could probably throw that in there. But generally, it's variations, and there's more than just the two genotypes that I threw up there. It's actually a very complicated genetic disease, but sort of to make it simple, I just put up the sort of normal versus abnormal. And so it's really based on the level of serum measurements of alpha-1 antitrypsin when you need to treat it. But you have to have at least one abnormal allele to have alpha-1 antitrypsin deficiency.
We're going to take a 5-minute break. Dr. Burkhardt, I'll stick around for a couple minutes if anybody has additional questions. Come back, though, in 5, and if you want to, in advance, log on to, what is it, RW Poll for audience response. We'll have a code for you in just a minute. Thank you very, very much. Okay. Yeah, sorry. You got the corrections that I sent to you. Where'd David go? Back to yeah, let me. Do we have our AV person here? Or anybody? Okay. Yeah. It's okay. Did you say hi, Dave? Okay. Got it? What was the problem? Yeah. Why don't you, actually?
All right, guys, we're going to get started. So, congratulations, you're almost through your pulmonary section. We've had 20 lectures so far. So, this slide is going to reappear in a few slides. It's also, your session ID is also written on the board. I still don't have any disclosures. The last 20 lectures have really been sort of a whirlwind tour through pulmonology. We all have spent years acquiring this information, so this is just a foundation on which to build. You're going to need this for everything you do in your medical career, unless you go into banking after medical school. But even then, it would be good to know, some of these things. So you've had talks about your lung anatomy and development. We've hopefully covered pretty thoroughly all of these things that your lungs are supposed to do. Ventilation, moving air in and out of the alveoli. Gas exchange, moving those gases across that alveolo-capillary membrane. Transporting oxygen through the blood. You've learned about when that goes wrong in a lot of different ways and how to treat that. We've tried to place lung disease in a broader context, not just the U.S., but the whole world. We've talked about diseases of the airways specifically. Asthma is a good example. Diseases of the lung parenchyma, interstitial lung disease. Diseases of the lung vasculature, you heard a lot about yesterday, along with your pulmonary embolism lecture, and diseases of the pleura, like pneumothorax, pleural effusion. And some diseases, as you've just heard, COPD, has overlap in airways and parenchyma. Sarcoidosis hits just about everything. You may be feeling like this little girl at this point and trying to drink out of the business end of a fire hose. And lots of people describe medical education as that experience. There's a lot of stuff to know to be a doctor. The good thing is most of the important things you're going to hear again and again and again and again. But still, you should try and get most of it now, because you're going to be tested on it. So. We have a lot of people. You've seen a sampling of them. Some of them have children who might be in this class. We have lots of different areas. It's not all just general pulmonary consultation. I've put down the 3 most important ones at the beginning, because I do sleep, and Dr. Bowman is an interventional bronchoscopist and a lung cancer screener. But we do lots of other things, and so we have a broad array of research interests too. This isn't for you to necessarily do anything with now, but you might want to refer back to it when you're thinking about what you want to do with your own careers and just professional lives. Everybody on this, and this is not a comprehensive slide. I've left lots of people off because some of which I couldn't remember what they did. You know, everybody is very, very approachable. We love working with medical students. We love working with residents. You know, please email, call, stop by. There's really always going to be an open door. So if you haven't logged in yet, please do. Oh no, this is, shoot. Well, let's see. How do I just reset? Did it work? No, it's still doing that.
So it's going to show, if you do a refresh.
Okay. For everything or just this one?
And I believe when you open the slide, it'll actually clear the results. Have you done a session reset?
I think I did already.
So you should be able
Session. But all my slides are still up, and okay, but that's...
I think, yeah.
Just a brief moment of, all right, so why don't we just go ahead and, hold on, now where's my, I don't have a control. Here it is.
the problem we were having.
Hold on. No, we've done this tons of times.
It's a well-oiled
There, yeah, you have to actually hit that slideshow start rather than the slideshow.
All right. What can I recover that?
And I think you're just going to have to wait for now.
While they're troubleshooting, just a couple of comments. As you heard at the very beginning of the course, are you guys ready?
No, go.
It's been
As you heard at the very beginning of the course, this is Dr. Atkinson's in my first year coordinating the course. We owe a lot to Dr. Lederer, who organized it last year. But we made some small changes. We're very open to suggestions of things that you thought worked, things that you'd like to see more of. Please feel free to email both of us with suggestions. You ready?
No.
it's lost connection.
Okay, well,
It's telling you that you've reset your connection.
so how y'all doing?
On a scale of 1 to 10 from a comedy standpoint, I don't. How do we compare to like cardiology? Were they better than cardiology? Okay.
That's a good
All right. There is a lot to learn in pulmonary medicine. Some of it's not completely intuitive, as we found out. We try and make it as low stress for you guys as possible. I'll also say you are going to be covering exams over the weekend, probably.
Killing this
There are a couple reposting some of the slides. Obviously, when you make a lecture with 100 slides in it, there's going to be little errors. We try to catch them as we go along and repost the corrected slides. I sent out emails to some folks with corrections. If you have any questions about the content of a particular slide, you think there's an error on it, or you just don't understand what's being said, just email either Amy or myself. I'm going to be up till about 10 o'clock on Sunday night, probably answering emails, but don't email me at like 1 in the morning and expect to get an answer. But up until 10 is fine. Does anyone have any questions about Dr. Burkhart's lecture or about COPD?
Oh, hold on. I wanted to make 2 points while this wonderful person is taking my 50 minutes. 2 points. You have had a couple of cases where people died or were nearly intubated because of opiates. Opiates are actually really good medications. So if you're on your surgical rotation and somebody's in a lot of pain, you should give them opiates. You should just do it carefully and monitor them because, you know, they have serious respiratory repercussions potentially. But, you know, I was just going through all of the lectures and like 4 people, imaginary people, died because of opiate administration, and that seems disproportionate. The second thing is to just introduce you to this concept of physiologic mediocrity, which is something that's really hard for medical students to accept. You've never been mediocre at anything in your life. But sometimes we're mediocre with our patients on purpose. And you can apply this to that concept of giving a hypercapnic COPD patient oxygen. You're not shooting for an oxygen saturation of 100. You're shooting for something like 90. So you're giving them just enough so that you can blunt all those hypoxemic, really bad consequences, and hopefully not make the worsening of the VQ mismatch problem really profound. This concept is also, hold that thought. This concept is also really important in ARDS when we take care of patients with really bad respiratory failure. We talked a lot, or at least a little bit, about lung protective ventilation or low tidal volume ventilation. And one of the consequences of that is that your alveolar ventilation drops, your carbon dioxide gets high. So we accept that. It's not a perfect state, but it's good enough. And we, when we're trying to oxygenate patients with bad ARDS, we're not shooting for a PaO2 of 100 or an oxygen saturation of 100%. We're shooting for a PaO2 above 65, basically. And that allows us to lower our fractional inspired oxygen content, because 100% oxygen over a long period of time is really bad for you. It irritates your airways, it can cause resorptive atelectasis, it can actually cause fibrosis. So we're trying to mitigate harm but keep you alive. So physiologic mediocrity is how we refer to it. This is really fun. I'm so glad we're using this. The spinning wheel of death.
So I'll spin some plates for 1 second then.
Okay.
So lung reduction surgery. This is one of the things that I work on at the South. I'm not a surgeon, but we work with the COPD patients. We have patients with really bad emphysema that tends to be in that the tobacco-related emphysema that tends to be upper lobe, central lobular emphysema because of where it affects the lobule near the terminal bronchiole. But the bottom line is they get really bad emphysema up here, okay? And their lungs down here are just a little bit happier, okay? But they have this problem of expiratory airflow limitation. They get a breath in and they can't get it out. They get a breath in, they can't get it out, and they hyperinflate. But they hyperinflate here more than down here. And what does that do? That squishes their good lung, okay? So not only do they have all this crappy lung up here, but their one area of good lung in their lower lobe is getting squished. And then they get these horrible flat diaphragms that can't move. Your diaphragms are designed to go from curve to flat, curve to flat, curve to flat. They start out flat, they can't move. So this person is having a horrible time breathing. They're having a horrible time oxygenating because their good lung is squished. They're hyperinflating because they can't get the breath out. Their diaphragms are flat. It's just a disaster. So somebody a number of years ago came up with this idea, well, let's just get rid of that portion of the lung. Let's just take out the worst portion of the lung. And their chest is still up here. This good lung shifts up into their thorax, and it just has more room to breathe. The diaphragm comes back up, and this healthy lower lobe just functions mechanically better. So we call that lung reduction surgery or lung volume reduction surgery. And it works, and it works if you select patients very, very carefully so they're not so sick.
Off the stage, Bowman.
All right.
All right. Quickly, how many hours of sleep do you get? Oh, I have to open polling? Here we go. And now. 0, 1 to 2, 3 to 4, 5 to 6, 7 to 8. It's not. Oh, session ID. Yes.
So if we can just drag that over to the other screen.
No, here. 689-228. 689-228. Sorry about like 14th session ID. 6-8. There's no question up. 689. Okay, good. All right. So hurry up, because this isn't terribly interesting. Okay, good.
Actually, permanent
Yeah.
session IDs that
All right. So, oh, wow. Really? I'm impressed. Nice. So, regular adults need how much sleep per night? Normal adults, most of them need how much sleep per night on a regular basis? And, all right, good. That's, yes. So, there's actually data about this. So you perform really badly if you are chronically sleep restricted. This is healthy college students at the University of Pennsylvania. They were divided into different groups. Did you do that? No. No, this is, okay. This was before your time. It could be just Penn students, but they were in 2-week blocks. You got to sleep 8 hours a night for 2 weeks, and this was all in a lab, so it wasn't honor system. 6 hours a night per week, 4 hours a night per week, and they did a lot of neurocognitive testing afterwards. And everybody did worse if you were under 7 to 8 hours of sleep per week. And this is psychomotor vigilance testing, which is you have a computer screen in front of you and like something pops up and you have to do it. So if you miss that, it's called a lapse. And this is, what is that? That's the Stanford Sleepiness Scale score, which is just a standardized questionnaire. This is digital subtraction, and this is serial addition and subtraction. So these are all just different tests. And actually, they had them do a driving simulator, too, and it was how many lane drifts you had. And even at 6 hours a night over two weeks, by the end of the 2 weeks, you did as badly as if you'd had 2 nights of total sleep deprivation. And the scariest part was that they didn't perceive that their performance was dropping off. So you stink at what you do, and you have no idea that you're that lousy. And this is a study in German medical interns and how they interpreted a whole series of EKGs. And post-call, they did a lot worse than after a night off duty where they supposedly slept. And also, this is just to point out all of your cognitive processes have a circadian fluctuation as well. So go to bed. But it sounds like you guys are good at that anyway. Okay, so all of the following shift. Oh, so it's 689228. It's not working? Yeah, we lost it again. Great. So how about take a minute and then I'm just going to go and how many think that increased pH shifts the oxygen dissociation curve right? No? Okay. How about, that's not how many of you think B is the correct answer? So how many of you think A is the correct answer to this question? All right, good. B, C, D. So, yeah, so I think, all right. So all the B, C, and D all shift your curve right. Increased pH, alkalemia, low hydrogen ion concentration, that shifts your curve left. So when you shift your curve right, it makes it easier to unload oxygen in the tissues. When you shift your curve left, it's easier to, it makes it more difficult to unload. So here we have a patient with ILD who has an oxygen saturation of 85% at rest. The major physiologic explanation for this hypoxemia is, and we have the choices, diffusion abnormality, VQ mismatch, shunt, alveolar hypoventilation, and low PiO2, which are your 5 causes of hypoxemia. So how many votes do we have for diffusion abnormality? Wow. How about VQ mismatch? Okay, shunt, hypoventilation, low PiO2. Okay, so that's great. And just, if you do a pulmonary clerkship or whatever on the pulmonary wards, the answer is almost always going to be VQ mismatch. So that's your clinical pearl today. So as you've learned, I think from my talks and from Dr. Lederer, VQ mismatch is really the primary mechanism. And diffusion problems really only get called into play during things like exercise or other stress that increases your cardiac output and decreases your transit time at the gas exchange zone. So a 50-year-old man with cirrhosis has the following ABG while breathing room air, and you can also assume that he's breathing, that atmospheric pressure is 760 millimeters of mercury, and R is 0.8. His pH is 749, PCO2 is 30, PaO2 is 98, and the oxygen saturation is 98%. So what is his AA gradient? And your choices are 5, 15, 25, 35, or cannot be determined. And I'll give you a little bit to do that. We did warn you that the alveolar gas equation was going to be on the test. All right, so how many takers do I have for 5? Or do you need more time? More time. How about now? Okay, so do I have any takers for 5? How about 15? You guys can do math. 25, 35. So, pretty straightforward. If you didn't actually get this answer, do this problem a couple times, or do every ABG question that we've given you so far. You should just be able to do this practically in your sleep. You're going to have to do this when you're taking care of patients on the wards. You shouldn't, you can get an app on your phone that'll calculate it, but it's not, it's just better if you know how to do it. And this is a respiratory alkalosis with alveolar hyperventilation and normal gas exchange. So this is a pretty characteristic gas for somebody who's got cirrhotic liver disease. A 73-year-old obese woman presents with shortness of breath, and she has the following PFTs. So her FVC is 66%, her FEV1 is 63% predicted, the FEV1 FVC ratio is 72% predicted, or it's just 72%. Her vital capacity, or sometimes you'll see it written SVC, slow vital capacity, is 59, total lung capacity 63, residual volume 70% predicted, and functional residual capacity is 68% predicted. So she has normal PFTs for a 73-year-old woman, an obstructive ventilatory defect, a restrictive ventilatory defect, or a combined obstructive and restrictive defect. Still spinning. All right, how many takers do I have for normal PFTs? Good. How many takers do I have for an obstructive ventilatory defect? Restrictive ventilatory defect. Combined. Okay, good. So you'll remember an obstructive ventilatory defect for this class and for lots of programs in the country is defined just by an FEV1 over FVC ratio of less than 70% predicted. Dr. Lederer referred to something called lower limit of normal, which is actually what we use in our PFT lab, but it's kind of complicated for this class, so we're going to teach percentages. So FEV1 over FVC ratio of less than 70% predicted is an obstructive ventilatory defect. In RVD, I'm glad nobody was fooled by the low forced vital capacity. You could teach some pulmonologists in the community that. We get lots of second referrals of people who've been diagnosed with OVD. I'm sorry, I'm glad you weren't fooled by the low FEV1. We get lots of referrals from pulmonologists who think that a low FEV1 means restriction, means obstruction, but your FEV1 is low because your FVC is low. You can't blow out more air in 1 second than you can in your total FVC maneuver. So you need those lung volumes to really diagnose the restrictive defect. And you can see in this patient, all of her lung volumes are reduced. And here are some representative flow volume loops. That's going to be, pattern recognition is going to be really useful to you through your clinical time. So a well-appearing 31-year-old woman presents with shortness of breath that wakes her from sleep most nights of the week. She has normal chest imaging, and her spirometry results are as follows. She has an FVC of 97% predicted pre-bronchodilator that stays the same post-bronchodilator. Her FEV1 is 52% predicted pre-bronchodilator, goes up to 80% post-bronchodilator, and her FEV1 over FVC ratio is 48, going up to 78 post-bronchodilator. So her most appropriate medication or medications include, and we have prednisone, inhaled beclomethasone, albuterol, or varenicline. So how many, and you can choose more than one if you think more than one are indicated. How many takers do I have for prednisone? Okay. How about inhaled beclomethasone? Okay. Albuterol? Good. And varenicline? Okay. So this correct answer is actually B and C. So you have an obstructive, she's a fully reversible obstructive ventilatory defect. She's 31. She has symptoms at night. I mean, this is very likely to be asthma. And since she has symptoms every night, she's, what kind of asthma does she have? Persistent, right. So she deserves an inhaled corticosteroid. So that's her controller medicine, and then she would need a rescue medication as well. She doesn't need prednisone. We haven't even given her any therapy yet, so we should at least see if our inhaled corticosteroid can get her under control. If she was in acute distress and couldn't move any air, and we were able to temporize her with emergency room therapy, we would definitely put her on systemic steroids, as I think happened in your second small group case, or in your reading at least. And then varenicline is a smoking cessation agent, as you just learned. We don't even know if she smokes, but if she does, that might be something to consider. So which one of these statements is not true? Occupational asthma is primarily immune-mediated, characterized by airway hyperresponsiveness, ruled out if the symptoms don't worsen at work and improve away from work, or treated by avoidance of the exposure and therapies directed generally toward asthma. So one of those phrases is not correct. All right, so how many people think A is the false answer? Okay, B? C? Okay, D. Yes, so occupational asthma is not at all ruled out if your symptoms don't vacillate with work, although that's a good clinical sign that you might have that problem, especially if it's immune-mediated. If you have the irritant-induced type, that can be really difficult to prove because you don't have that temporal worsening. Yes?
Oh, I should ask, the previous patient with the severe asthma, the chronic severe asthma,
Yes.
is there a particular indication for which you give the SABA in addition to the corticosteroid, or is it just adjustable?
No, I think anybody who's on a controller medication needs a short-acting bronchodilator. So you could actually, it's more a style matter. You could start with a lower dose inhaled corticosteroid and add a LABA, or you could start with a higher dose inhaled corticosteroid and not add the LABA right away. So that's mostly a style issue, but those are both valid choices. Okay, so I think everybody got this right, so we don't have to spend a lot of time on that. A 16-year-old with CF has an increase in cough and weight loss. The chest X-ray shows bronchiectasis bilaterally, worse in the left upper lobe. She has a temperature of 39 Celsius. Her respiratory rate is high, 33, and her oxygen saturation while breathing room air is a little low, 93%. The organism most likely responsible for the decompensation is strep pneumo, Pseudomonas aeruginosa, Mycoplasma pneumoniae, RSV, or strep pyogenes. Okay, how many vote for A? B? C? C, D, E. Yes. So this is a graph that Lynn Quittel used. Pseudomonas is a huge problem in CF patients and associated with a lot of their morbidity as they get older and older. But certainly don't forget about staph, which is very common in everybody and is also common in CF patients. Which of the following is not a criteria for the diagnosis of ARDS? Bilateral pulmonary edema, hypoxemia, a plateau pressure greater than 30, symptoms within 7 days of a likely insult, or symptoms are not fully explained by cardiogenic pulmonary edema. How many votes for A? Good. B, C, D, E. Okay, so a little more heterogeneity. So this is the Berlin definition of ARDS, which is the newest ARDS definition, and Dr. Agerstrand introduced you to this. So you have to have a likely insult. I mean, you can't have like, I don't know, in mosquito bite 7 days before. I mean, it has to be something that you know is likely to proceed to ARDS within 7 days. So we're not counting the pneumonia you had 3 months ago. Chest imaging, bilateral pulmonary infiltrates that are not fully explained by something else. The respiratory failure cannot be fully explained by cardiogenic pulmonary edema. So you're allowed to have pulmonary edema from your heart, from your lousy LV function. It just can't be the entire reason that your oxygenation is so bad. And then these hypoxemia classifications give us a little more prognostic ability because each of these groups is associated with a different mortality outcome. So the early phase of ARDS, we're still on this ARDS topic, is characterized by which of the following pathological findings? So you are going to have some path on your exam, I believe. Hyaline membrane formation, type 1 pneumocyte necrosis, interstitial fibrosis, type 2 pneumocyte proliferation, and last choice is both A and B. So how many votes for A? Okay. How about B? Okay. C? D? And E? Yeah, so E is the right answer. You get both hyaline membrane formation and type 1 cell necrosis. And these are the pink thickened hyaline, that's the hyaline deposition in those membranes. All of the following are associated with increasing risk for sleep apnea except obesity, male gender, systemic high blood pressure, hyperlipidemia, or micronathia. This may be a little harder. Okay, A, obesity. B, male gender. C, systemic hypertension. D, hyperlipidemia. And E, micronathia. Okay, so I don't think he specifically talked about craniofacial abnormalities, but there are a lot of them that predispose patients to obstructive sleep apnea, and by he I meant Dr. Basner. So hyperlipidemia is the correct or the false answer in this group. Male gender and obesity are clearly the biggest risk factors for obstructive sleep apnea. If you're not a man or not overweight, it doesn't mean that you're excluded from having sleep apnea. I probably have 10 to 15% of my patients are at ideal body weight, body mass index, or even on the low side. After women have much less OSA up until about menopause, at which point the prevalence starts to approach each other. And then, if you have a small or recessed lower jaw, if you have big tonsils, a big uvula, if your soft palate is very, very long or redundant, those are all risk factors. Having a size 18 collar in your shirt for a man or larger are risk factors. First-degree relatives. And that's probably, having a first-degree relative with sleep apnea increasing your risk is probably multifactorial. You have the same genes, you probably have the same airway anatomy. You also eat the same, you grow up eating the same food. So if everyone in your family is 420 pounds, you're not likely to be 75 pounds. So there are probably a lot of factors that go into that. And then, obese, hypertensive male veterans who snore have like a 95% prevalence of obstructive sleep apnea. So things travel together. In which patient of these following patients is it appropriate to send a D-dimer in the diagnostic evaluation of suspected PE? So first we have, boy, this is small writing, a recent DVT, now with new onset of chest pain and tachycardia. Choice 2 or B is a history of DVT PE, now with symptoms of DVT and dyspnea. Choice C is lung cancer, currently hospitalized, now with hemoptysis, tachycardia, and dyspnea. Choice D is history of a DVT and PE, recent knee surgery, now with chest pain, leg swelling, and tachycardia. And the last choice is none of these patients are appropriate for D-dimer testing. So you want to send a D-dimer in which patient? A, B, C, D, E. And the E's have it. All of these A, B, C, and D, your suspicion of DVT-PE is very, very high. D-dimer testing is not appropriate for the, yes? I'm sorry?
Why do you send a D-dimer if you only send it if you have low suspicion?
Because the value of a D-dimer is it has very good negative predictive value. It has lousy positive predictive value. So anybody who has risk factors or has other complicated medical problems, like a D-dimer is almost useless in someone who's sick and in the hospital because they have 1,000 reasons to have, maybe not 1,000, but like at least 15 reasons to have a high D-dimer. But if you have a patient coming from the outside who's relatively well and just has symptoms that you are thinking about, that sounds like it could be a DVT or, I don't know how to explain this sudden onset of shortness of breath otherwise. If that D-dimer is negative, the likelihood of you having a venous thromboembolism is so low, you can stop doing anything more invasive. So it can save you from doing things that require radiation exposure or an IV or things like that. But it's only in low risk, low prevalence populations and not appropriate for, so all those other patients should have gone straight to like chest CTA, or if they had kidney impairment and had a good enough baseline chest x-ray, could go to VQ scanning. We don't use pulmonary angiography a whole lot because it's much higher risk and it's it's a lot more invasive, but every once in a while you need to go to pulmonary angiography. So choose the false statement of the following regarding asbestos-related lung disease. A, your risk of lung disease is higher with amphibile versus Chrysostil exposure. Brett Favre. B, pleural plaques are associated with asymptomatic disease. C, smoking increases the risk of lung cancer related to asbestos exposure tenfold. And D, asbestos-related lung disease is characterized by an intense inflammatory response. So which is the false statement in this group? A, B, C, D. Okay, so asbestos, D is the false answer. It's a fibrotic response. Dr. Patel emphasized that a few times. There's really no inflammation seen there. It's really, it's all fibrosis. Pleural plaques and asymptomatic disease, pleural plaques you can see on a lot of different chest imaging in people who are like, I have an old patient who was a shipbuilder in the Navy and has really impressive pleural plaques. And he doesn't actually have symptomatic asbestos-related lung disease. He has sleep apnea. And then just that point that asbestos exposure and smoking are incredibly synergistic in terms of lung cancer risk. So hopefully nobody's exposed to asbestos anymore, but smoking makes it a lot worse. Patients with acute PE will have a primary respiratory alkalosis due to A, increased dead space ventilation, B, increased total minute ventilation, C, decreased cardiac output, or D, poor tissue perfusion. So I'm going to give you just a few seconds to think about that. Okay, how many takers do I have for A? B, C, and D. Okay, so the answer here is actually increased total minute ventilation, and we put this up there because this is a tough one. So huge PE can definitely increase your dead space ventilation, but the primary response is, as Dr. Brenner tried to emphasize during his talk, is that you increase your total ventilation, you increase your respiratory rate, and sometimes your tidal volume, and that is a much bigger driver of a respiratory alkalosis. Increased dead space ventilation would actually tend to give you a respiratory acidosis, right? Because you're not exchanging as much gas at that gas exchange barrier. And certainly with a big PE, you could decrease your cardiac output, but that would also tend to give you an acidosis. Okay. A patient with recent surgery, diagnosed with a DVT, high concern for bleeding with anticoagulation. Which treatment is the most appropriate initial therapy for DVT? So high risk of bleeding, initial therapy. A, warfarin, B, unfractionated heparin, C, rivaroxaban, and D, apixaban. How many votes do I have for warfarin? A. Okay, how about B, unfractionated heparin? C, rivaroxaban, D, apixaban. Okay, good. So I think most people got that. Warfarin it's reversible. You can give vitamin K, so that's not a terrible choice for someone who's bleeding, but it's completely the wrong choice for initial therapy for DVT. And if you give it without covering with something like unfractionated heparin or low molecular weight heparin, there's this complication called warfarin-induced skin necrosis that can occur. So you never give warfarin on day 0 of your PE. And then rivaroxaban and apixaban are now FDA approved for initial therapy, but are not reversible, so are not good choices in our patient who has a high risk of bleeding. Which of the following causes of hypoxemia result in an abnormal AA gradient? Choose all that apply, and everybody should get all of these right. Shunt, low PiO2, diffusion abnormalities, alveolar hypoventilation, or VQ mismatch. How many A's do I have? Everybody raise your hand. How many B's? Don't raise your hand. C, raise your hand. D, and E. All right, so good. So just memorize that, and it's really important and useful. Yes? Yes, exactly. Sorry? Oh, unfractionated heparin is what we talk about with, is like the IV heparin. And I didn't even put low molecular weight heparin in, which is not, I mean, you can just not give the next shot. So it's not very reversible, but its half-life is short enough that it doesn't stay around forever. So if you have a high risk of bleeding, you turn off the unfractionated heparin, and your PTT starts to normalize right away, and you can give something to fix it within 20 minutes. So that's a better choice in high risk of bleeding. I hope everybody has a high risk of breathing. On the ventilator, the measurement that most directly correlates to lung and chest wall compliance is A, peak pressure, B, plateau pressure, C, PEEP, D, peak pressure minus plateau pressure, or E, peak pressure minus PEEP. How many people vote for A, peak pressure? B, plateau pressure? C, PEEP? D, peak pressure minus plateau pressure? E, peak pressure minus PEEP. Okay, so let's go through all your lung compliance and airway resistance measurements on your ventilator. So plateau pressure, lung and chest wall compliance. So those who chose B are correct. And that as we talked about, on the ventilator, you perform an inspiratory pause. So you just hit a button and the ventilator pauses, and you measure pressures at that point, and that reflects what's coming from your alveoli and your chest wall. Your peak pressure is what your airways are seeing, really, and it's on top of of the pressure that you already have at plateau. It's the additional pressure. So it's a combination of airway resistance and your lung and chest wall compliance. And then that gradient, the peak pressure minus the plateau pressure, is that airway resistance component. And then PEEP is just what's left in the respiratory system at end expiration. It's sort of stenting open your airways and your alveoli. Okay. Patient has the following ABGs: pH 7.15, PCO2 60, PO2 65. What is the acid-base abnormality? A, acute metabolic acidosis. B, chronic metabolic acidosis. C, acute respiratory acidosis. And D, chronic respiratory acidosis. And just some testmanship here. This is not the renal section, so the answer is going to have the word respiratory in it, probably. So do I have anybody who still wants to vote for A or B? There's always one. C, acute respiratory acidosis. D, chronic respiratory acidosis. Okay. So, so first, we know it's an acidosis because your PCO2 is elevated, alveolar hypoventilation. Your pH is very low. It's under 7.3. The kidneys haven't had time to react and generate bicarbonate to buffer all that hydrogen ion. So this is an acute respiratory acidosis. This is the harder one. All of the following can be measured with a simple spirometer and a stopwatch, except for tidal volume, FRC, vital capacity, total minute ventilation, or total or minute ventilation, respiratory frequency. All right, so you have just a regular old spirometer, and you have a timepiece. Do I have any votes for A? So this is something you cannot measure with the equipment provided to you. A, tidal volume. B, FRC. C, vital capacity. D, total ventilation. And E, respiratory frequency. Okay, good. So yeah, here's your pulmonary function testing graph with all of your different capacities and volumes. And so when you have a spirometer, you just have somebody do tidal breathing, so you can measure that with the spirometer. You have them at one of their end expiration, you have them take a deep, deep, deep breath all the way up to total lung capacity, which you can't actually measure with that, but that's what it, because we don't know what the bottom is, but we know what the top is. And then you have them blow the air out as fast and hard as they can and hold that for between 6 and 10 seconds. So you can measure all these things except for FRC, because you need that residual volume that isn't measured by a spirometer to calculate FRC. And so everything else can be measured. So just be familiar with the capacities and lung volumes and understand how they work. So a 65-year-old man with renal insufficiency. Oh, I'm really late. Do you guys want to do a few more questions, or you can leave and go to your small groups? All right, a 65-year-old man with renal insufficiency presents with shortness of breath and chest pain. Your physical exam reveals no breath sounds and dullness to percussion at the left lung base. The chest X-ray confirms a serosanguinous but not pussy, not purulent pleural effusion, reaching a third of the way up the hemithorax on the PA film. You perform diagnostic thoracentesis, and you get the following values. The LDH of the pleural fluid is 70, of the serum is 150. The protein in your pleural fluid is 5, and of the serum is 7. In your the pleural fluid glucose is 5, and the serum glucose is 90. So your next management step, and I'll go back to those if you like, is to start furosemide and optimize his heart failure regimen. B, to monitor with weekly chest x-rays and drain the effusion if the volume fills greater than 50% of the hemithorax. C, insert a chest tube and drain the effusion. Or D, initiate dialysis to reduce volume overload. So these are your values. Anybody want more time? Okay, so how many votes do I have for A, diurese? B, monitor conservative management. C, chest tube. D, dialysis. Okay, so this answer is the chest tube, and that's because of this glucose. So you know it's a transudate or exudate. Exudate, right? Your total protein and LDH ratios are abnormal. They're not both abnormal, right? Your LDH on, I think, if I set this up correct, yeah. So the LDH is not, that ratio is not elevated. You don't need all of the values to be abnormal. You just need to meet one of Light's criteria for it to be an exudate. That met it on the protein basis. The pleural fluid protein to serum ratio is greater than 0.5, and then so you know it's an exudate, and you have to figure out what to do with it. And that glucose of 5 tells you that it's a complicated effusion, and that's something that needs to be managed right away. Because if you don't, if you leave it in there and you just watch it to see what happens, you're going to fibrose the the lining of your pleural space, and you're going to end up getting in that one of those rinds that Dr. Goldman showed you a picture of, and trap the lung. And then even if you go in later to drain it, that lung is not going to re-expand. So there's this old saying, did you learn this too? Oh, don't let the sun set on a pleural effusion. In reality, we let the sun set on a lot of pleural effusions, but not they're in patients who have clear heart failure and bilateral and all that stuff. So you don't have to necessarily stick a needle in every person who comes along, but certainly in this case, you would. This is a little bit of a hard one too sometimes. If your carbon dioxide production at the cellular level is constant, alveolar ventilation is increased threefold. The alveolar PCO2 after a steady state is reached is what percentage of its former value? 3, 25, 33, 100, 300. Anybody want more time? Okay, so, I didn't even ask you. A, 3. B, 25. C, 33. D, 100. E, 300. Okay, so everybody got that. Most people aren't no longer interested in this class. So they're inversely proportional. If you elevate one, the other goes down, vice versa. And we should probably let you get ready for or move on to your small group. I will put all of these up on Courseworks. They've all got answers that go along with them. Sorry about the technical difficulties, and good luck. You guys are going to do great on your test. Man, what a bummer.
Yeah, that's it kept logging you on and then kicking you off.
Yeah, I had like...
It must have been an internet connection problem. I think it actually went relatively quick with the feedback.
Bummer.
I'm sorry about that. I have
It's
no
not,
idea
you're
what
not
happened.
responsible for
No. It's frustrating.
Thanks for helping. change in pressure, I'm sorry, this change in volume and this change. So delta pressure to give you a certain delta volume, we saw, in this case, we went from 5 to 30, and we saw that change was 500. 500 over. But if you're just saying, what the flex volume to the lungs, you're absolutely right. This is included. If we knew what the starting volume was.
Sorry, I'm going to also shut down because I'm actually leading somebody's small group today. So, yeah, that's great. So there are lots of different.
Yes, if we're saying what number in this system tells us what state of compliance
There
we
are
want.
a ton of different things that we do.
So we see, and so when we're talking about keeping plateau pressures low for ABS, we want to see them under 30. This person has stiff lungs, it might be up here at 40. Okay? Very, very stiff lungs, very, very compliant lungs might be down here at 20. So this number, including the total number of the plateau, it tells us how stiff the lungs are. You're asked to calculate it, do the change from one pressure to the other pressure. Yes. Just because that's your volume change. Your volume change might be here to here. Your pressure change might be here to here. That's so your small group, your small group leader, I have to get down to small group 2. Your small group leader is going to stay late today, hopefully. Who's your small group? Oh, yeah. So stick around afterward. Ask other questions. Feel free to email me some questions too. It's totally fine. I mean, 207, second floor down. Yeah.
So if you wanted to do
Thank you. Did you need something? Or? No, just making sure that you guys are all set. Oh, no, I appreciate it. Thank you.